So next is pulse oximetry. It's V30. How does pulse oximeter work? So this works on the principle of Beer-Lambert law. Oxygenated and deoxygenated hemoglobin optimally reflect different wavelengths of incident light. So pulse oximeter has two different light emitting diodes at two wavelengths and a sensor. So one light going is 660 nanometer. That's red light and measure the total amount of hemoglobin. The other one is 940 nanometer infrared light, measures the oxygenated hemoglobin. A percentage of saturated hemoglobin is calculated from the ratio of the two. Pulse oximeter is able to isolate pulsatile dynamic arterial signals from the static venous component of the vascular bed. The pulse oximeter then displays the percentage oxygen saturation of the arterial blood. A probe is attached to the finger or earlobe. Some probes can also estimate the pulse ox volume. How do you interpret a pulse oximeter saturation, SaO2 or AbG-PaO2 reading? SaO2 and PaO2 are meaningless without the knowledge of FiO2, concentration of inspired oxygen. A normal PaO2 on room air is 12 kilopascal, and considering that normal concentration of oxygen in the air, that's 21%. A ratio of partial pressure of oxygen to FiO2 should be 0.6. A partial pressure of 12 in a patient with FiO2 of 40 is clearly hypoxic. That's 12 divided by 40 is 0.3. And partial pressure of oxygen has a non-linear relationship to the saturation, although the two are often confused. Saturation can be normal despite a low partial pressure of oxygen in the acute pulmonary embolism, reinforcing the need for ABG in acute respiratory failure. It must be remembered that pulse oximetry does not assess ventilation. End-tidal carbon dioxide and capnography must be measured. What does oxygen delivery depend on? Hemoglobin concentration, cardiac output, oxygen saturation, SaO2. A drop in SaO2 is picked up more quickly with pulse oximeter than the clinical observation for peripheral cyanosis, and oxygen saturation must drop to 60 to 70% before cyanosis is observed. What are the pitfalls and sources of error in the pulse oximeter? Cold peripheries, poor tissue perfusion, abnormal pulses due to atrial fibrillation and tricuspid regurgitation, carbon monoxide poisoning in fire victim and the smokers, and there will be a 20-second lag between the physiological values and the saturation regarding on the reading. Nail varnish can prevent the penetration of light, and electrical interference from the diathermy. High ambient light can interfere with the incident light from the pulse oximeter, and movement and shivering can affect the signal. What is methemoglobin and how does its presence in the blood affect a pulse oximeter? Methemoglobin has iron in a ferric state, but normally our hemoglobin has in a ferrous state as a normal hemoglobin. Therefore, methemoglobin molecule has a reduced oxygen carrying capacity. As the levels of methemoglobin increase in the blood, the pulse oximeter values decrease until the saturation drops to 85%. Saturation reading does not decrease further even though amount of methemoglobin be increasing. It can be congenital due to deficiency in the methemoglobin reducing enzymes NADH methemoglobin reductase are required, resulting in the pollutant water with nitrate or use of local anesthetic purilocaine. A direct measurement of oxyhemoglobin by a co-oximeter pulse gas analysis is required to supply the diagnosis. Treatment is by administration of reducing agents such as methylene blue.